So the way I choose to use Notify isn't necessarily a pick and choose for the patient. I mean, I think I have made this just part of my Dr. Gordon guidelines, if I can say that. The way I practice is that if you have a nodule that qualifies between 8 and 30 millimeters and you meet all the entrance criteria, that this should be offered to a patient. The only reason we wouldn't is for whatever reason a patient does not want to pursue this, which I have not had that experience. And so we just incorporate it to anybody that has a nodule that's coming in that is intermediate risk should be offered this test up front because we can get results so fast with a secondary plan already in motion. Whether that may be a biopsy, maybe that's a PET, maybe that's a surveillance. And so that's already kind of teed up, and then we'll use this test to say, yes, that's the right next choice, or wait a second, maybe that's not the best next choice, and we can change how we approach it. So that's how we utilize it. So in my opinion, really, and our hope is that this is part of the real guidelines, the ones that matter. But this is just part of the algorithm of what to do next.
So how do I pick which patients to do Notify on? If you meet the inclusion criteria. So in other words, I need you over the age of 40. I need you to have a nodule risk calculator that is, more than 5% risk of cancer and less than 65% if I want to do CDT and less than 50 if I want to do XL2. Can't have had a solid malignancy in the last 5 years. Need to be over the age of 40, right? Otherwise, why would I not send this, right? The test is covered, so I'm not worried about that. So I'm not worried about hitting my patient with some weird bill. It's quick enough that, like, even if the plan is to bronch you, I'm not going to bronch you tomorrow, so I'll get the Notify back, right? You need a procedure? Fine. We've got plenty of time to get it done. Well, let's make sure you're the right person getting it done.